Bismillahir Rahmanir Rahim. Our subject today is bradycardia and heart block. Your lecturer will be Dr. Hisham Saif, Assistant Professor of Cardiology and Director of Cardiac Electrophysiology Unit, which is concerned with the treatment of cardiac brady as well as tachyarrhythmias. We will start by defining bradycardia and heart block. By bradycardia, we mean any heart rate below 60 beats per minute in adults. As in children, they have higher rates to be considered as bradycardia. By heart block, we mean any delay or interruption of propagation of electrical impulse in cardiac conduction system, which can be associated with bradycardia or not. When it comes to the etiology of the bradyarrhythmia and the heart block, degenerative heart disease being the most common cause of pacemaker implantation, which occurs in old age. Also, bradyarrhythmia and heart block can occur physiologically during sleep, severe pain, severe hypertension, and in highly trained athletes. Congenital complete heart block can occur in babies of mothers with autoimmune disease. Usually the patient is tolerant to bradyarrhythmia and pacemaker implantation will occur in early adulthood. Also, inflammatory carditis, which occurs in autoimmune carditis or in viral myocarditis. Infiltrative heart disease like hemochromatosis and amyloidosis is another cause of heart block and bradycardia. Iatrogenic bradycardia can occur by prescribing medications which slows the heart rate or induce heart block like beta blockers, calcium channel blockers, and digoxin. Also, it can occur due to surgical trauma during valve implantation or closing an AST or VST. Endocarditis is a common cause in cases of abscesses occurring around the aortic valve. Ischemic heart disease is a very important cause of bradyarrhythmia and heart block. In this entity, we have two types of myocardial infarction: anterior myocardial infarction, in which bradyarrhythmia and heart block will not occur frequently, but if it happens, it is usually serious and non-reversible and requires pacemaker implantation, while it occurs more frequently in inferior myocardial infarction, but it is benign and transient and usually will not need pacemaker implantation. Also, electrolyte disturbance or electrolyte imbalance occurring during renal failure is another cause of bradyarrhythmia and heart block. Presentation of the patient with bradyarrhythmia and heart block can be very variable. The patient can present with an acute presentation to the emergency department with syncope, which is due to cerebral hypoperfusion, chest pain, which is due to coronary hypoperfusion, shortness of breathing, which is due to accumulation of fluids in the lungs or hypoperfusion of the muscles. The patient can also represent with subacute or chronic symptoms to the outpatient with cerebral hypoperfusion inducing dizziness and muscle hypoperfusion inducing easy fatigability. Also, the patients can be asymptomatic and discovered during physical examination or during ECG in cases of a patient with congenital complete heart block, which are very tolerant to the bradycardia, as we mentioned before. Investigations. Investigations will concentrate in two directions. The first direction in detection the bradycardia and the type of bradycardia, and the other direction in determining the cause of bradyarrhythmia or heart block. In determining the type of heart block, 12-lead ECG is very important in diagnosing the type of bradyarrhythmia and heart block, in which we will concentrate in our lecture. If the bradyarrhythmia and heart block is not frequent or not present in the resting ECG, Holter monitoring, which is an ambulatory ECG recording, can be done from 24 hours up to 7 days of continuous ECG recording, and then interrogation of the device and detection of the intermittent cause of fainting or dizziness as being or coinciding with bradycardia or heart block. In patient with very infrequent symptoms, we can start event recording, in which the patient will attach, or the relatives will attach the event recorder to the patient while he is having the attack of fainting, and then they press a certain button and the event recorder will start recording. Then we interrogate the device and discover the type of bradycardia inducing syncope for the patient. In some cases in which we cannot easily find the cause, we can do electrophysiological study in which we measure different conduction velocities in different parts of the conducting system through a catheter catheters introduced in the venous system of the patient. Also, we can discover the cause of the bradyarrhythmia and heart block by doing an echocardiography, like in cases of degenerative heart disease, in which we find calcification around the aortic valve, which is extending usually to the AV node or the bundle of His, which is the cause of blocking its function. Also, laboratory tests like thyroid function and electrolyte levels can give us a hint on the cause of bradyarrhythmia and heart block. In this picture, we can see the Holter monitor, which is a very small device which is strapped to the patient by 5 or 7 electrodes, and it can record up to 7 days of continuous ECG recording. This is the event recorder, which is a small device only attached by 2 wires. The relatives or the attendants of the patients can attach it to the patient during the attacks of fainting and press the button to record the electrical activity during the attacks. Also, this is a picture of the catheters during electrophysiologic study, in which we introduce different catheters to different parts of the heart, like the ventricle, the AV node and bundle of His, the coronary sinus, and the atrium, to record different electrical activities of the heart and to induce arrhythmias if we want. So, based on ECG, what are the types of bradycardia and heart block? The first type is sinus bradycardia, in which the heart rate is below 60 beats per minute. The SE nodal block, in which there is an abnormality in impulse formation or impulse conduction in the perinodal tissue, which is outside the scope of the undergraduates. The AV nodal block, which is either due to an abnormality in conduction in the SE node or the bundle of His. Bundle branch block, in which there is an abnormality in conduction in either the right bundle or the left bundle. First, let's tackle the sinus bradycardia. So, if we have an ECG like this, the first thing to do is to determine the heart rate. Here, first we count the number of the big squares, which will be 1, 2, 3, 4, 5, and let's see 6 big squares. The heart rate in this case will be 300 divided by 6, which will give us 50 beats per minute. So the heart rate here is 50 beats per minute, which is below 60 beats per minute. Also, let's check the PR interval. the PR interval will be one big square, and the big square is 200 millisecond, which is the higher normal for the normal PR interval. Regarding the duration of the QRS complex, it will be here like two small squares, which is about 80 millisecond, which is less than 120 millisecond. So in this ECG, the only abnormality is the heart rate below 60 beat per minute, which indicates a sinus bradycardia. Now let's see how the AV nodal block will look like. The key idea here is that the signal is getting through the AV node all the time, but taking a little longer than usual, and we will call this first degree heart block. Or the signal is getting through the AV node some of the times, and we will call this second degree heart block. Or the impulse will not go through the AV node, and we will call this the third degree heart block. Regarding the first degree heart block, the SA nodal impulse formation and conduction is normal. The conduction of electrical impulse through the atria is normal, so the P wave is normal, but the AV nodal conduction is slower than normal. The normal PR interval should be between 120 milliseconds and 200 milliseconds. So if the PR interval is longer than 200 milliseconds, this is the first degree heart block. Then the rest of the conduction through the bundle branches is normal, so the QRS is normal. Here we can see that the PR interval is more than 0.2 seconds or 5 small squares or 200 milliseconds. So the PR interval from the beginning of the P wave to the beginning of the QRS is more than 200 milliseconds. The QRS is normal. Here in this picture, we can see that there is a P wave, PR interval, QRS, and T wave. The heart rate is 1, 2, 3, 4. So 300 divided by 4 equals 75 beat per minute. But here we can see that the PR interval is more than one big square. So this strip is showing a first degree heart block. Also in this example, the PR interval is 1 big square and 1, 2, 3 small squares, which is 8 small squares, which equals to 320 milliseconds, which is larger than 200 milliseconds. So what is the clinical significance of first degree heart block? It has no clinical significance, it needs no treatment, but we should check this patient frequently for fear of progress of this block to second or third degree heart block. Regarding second degree heart block, it is divided into 3 types. First, Mobitz type 1 or Wenkebach heart block, Mobitz type 2 or 2-to-1 AV block. Second degree heart block Mobitz type 2 or Wenkebach heart block was discovered by the German physician Carl Friedrich Wenkebach in 1899, in which the conduction through the AV node is progressively delayed until one beat is dropped. In second degree Mobitz type 1, PR interval prolongs with each beat until a dropped beat is seen. the PR interval is not constant. After each dropped beat, the PR interval is normal and the cycle starts again. As we can see here, the PR interval at the beginning of the recording is normal. In the second cycle, the PR interval prolongs more. In the third cycle, the PR interval prolongs more and more. By the third cycle, the P wave occurs, but there is no QRS conduction here. And then the P wave comes at its time, followed by short PR interval one more time and normally conducted QRS. In this rhythm strip, we can see that the intervals between the QRS is not constant, so there is grouping. The PR interval here is 5 small squares, which a high normal for the PR interval. The second cycle, the PR interval is prolonged and the QRS is normal. The third cycle, the P wave is not followed by QRS, so one QRS is dropped. Then the fourth cycle, the P wave is coming normally and the PR interval again is normal. The following cycle, the PR interval is prolonged, and the next cycle, the P wave is not followed by a QRS. So there is a gradual prolongation of the PR interval until one is dropped, and then the PR interval is short again, because there is recovery in the conduction in the AV node. Here the disease is usually in the AV node and not in the bundle of His. So what is the clinical significance of the Mobitz type 1 Wenkebach type of second degree heart block? The patient is usually slightly symptomatic with some lethargy and confusion. There is no pacing needed in this case because the disease usually in the AV node, and the disease in the AV node usually is recoverable. These patients should be closely followed up because this type of heart block can progress to a higher degree of heart block. Second degree heart block, Mobitz type 2. Here the conduction through the AV node is constant, meaning that there is no gradual prolongation of the PR interval. But occasionally and without warning, one P wave is not conducted. As we can see here in this example, in the first cycle, the PR interval is normal. In the second cycle, the PR interval is normal. In the third cycle, the P wave is not conducted to the ventricle as there is no QRS following the P wave. Then the P wave is coming in its usual time with a normal PR interval, and the cycle will continue again. In this rhythm strip, we can see that in this cycle, the PR interval is normal. In the following cycle, the PR interval is still normal. In the third cycle, the P wave is not conducted to the ventricle, then followed by a cycle with normal PR interval. The following cycle is also normal. And in the third cycle, there is a drop in conduction to the ventricle without prolongation of the PR interval, and so on. So the conduction is interrupted suddenly from the atrium to the ventricle without gradual prolongation, and this characterizes the disease in the bundle of His. So what is the clinical significance of the Mobitz type 2 second degree heart block? So what is the clinical significance of the type 2 second degree heart block or Mobitz type 2? It is clinically significant as the disease occurs in the bundle of His, and usually the patient is treated with a pacemaker implantation, and it can easily progress to third degree heart block. Now, what about the second degree heart block with 2-to-1 conduction? Usually we are not able to classify whether this is a Mobitz type 1 or Mobitz type 2. It's a particular type of second degree heart block. The ratio of the B to QRS is 2-to-1. Here we can see the following. The first cycle, the P wave is conducted with short PR interval, followed by a P wave which is not conducted, followed by a P wave which is conducted normally, and then it is followed by a P wave which is not conducted. So for each 2 P waves, there is 1 QRS. That's why it is called 2-to-1 conduction. So in this condition, we cannot determine whether this is a less severe type of disease, as in cases of second degree Mobitz type 1, or more advanced degree of disease of second degree heart block, as in Mobitz type 2, as there is no second cycle which will show that there is a gradual prolongation or there is a sudden drop of the P wave. So what is the clinical significance of this type of second degree heart block? The clinical significance is undeterminable. This will be associated with symptoms like dizziness or lethargy, as the degree of block is higher than the other types. Sometimes the treatment will be pacemaker, and this patient should be followed up closely as this patient can progress easily to third degree heart block. And now what about the third degree heart block, or what is called the complete heart block? There is a complete failure of AV nodal conduction. So there is no impulses from the sinus node will pass through to the ventricles. Some parts of the conducting system will take over as a pacemaker of the heart, which is called the escape rhythm. It can sometimes happen in the junction or the bundle of His. Here the escape rhythm will be narrow, or it can happen in the ventricular myocardium. Here the escape rhythm will be wide and the heart rate will be slower. In the third degree heart block, the P wave rate is normal. The ventricular rate usually is slow, and the ventricular complexes may be broad if the escape rhythm is idioventricular, as we said before. And there is a complete dissociation between the P waves and the QRSs. In this example, we can see that the P wave is going in regular manner, and sometimes it is buried inside the QRS, and QRS is going in a different manner, and there is no relation between the P waves and the QRSs. As we can see here, the heart rate is 1, 2, 3, 4. It is not bradycardic, so the ventricular rate is above 60 beat per minute, and the atrial rate is at different rate and regular, and there is no relation between the P's and the QRSs. So this is a third degree AV block. What is the clinical significance of the third degree AV block? Usually, the patient is having symptoms of low cardiac output. The patient is confused, dizzy, with low blood pressure. It can lead to standstill, ventricular tachycardia, or ventricular fibrillation, what is called the Stock-Adam attacks with loss of consciousness. The treatment is pacemaker. Then we come to the bundle branch block. The first type of bundle branch block here is the right bundle branch. In this example, we can see that the heart rate is above 60 beats per minute as 1, 2, 3 divided by 300 divided by 3, it will equal 100 beats per minute. So there is no bradycardia. The PR interval is less than 1 big square, so it is normal. The QRS duration here is more than 3 small squares, so there is some kind of bundle branch block. Here we can identify the right bundle branch block by the following. If we look at V1, we will see an M pattern, which is called the RSR pattern in V1, and a wide S in V6. And this characterizes the right bundle branch, the M pattern in V1. In this example, we can see that the heart rate is above 60 beats per minute. The PR interval here is normal. It's about 1 big square. The QRS duration is more than 3 small squares, so it is more than 120 milliseconds. But here we can see the M pattern in V6, which characterizes the left bundle branch. M pattern in V6 and wide S in V1, which characterizes the left bundle branch. Now to the treatment of heart block. First, in acute situations, if the patient is stable, we should admit the patient and start monitoring the patient for fear of increase or advance in the degree of heart block. If the patient is unstable, the patient should be monitored and we should insert a temporary pacemaker. We should monitor the patient, and during that time you should remove the offending agent if the patient is taking certain medications like beta blockers, calcium channel blockers. It should be stopped for the proper duration. If there is electrolyte disturbance, should be treated. If there is hormonal disturbance like hypothyroidism, the patient should get replacement therapy, etc. In cases in which there is no temporary offending agent, the patient should undergo pacemaker implantation. We have two types of pacemaker: a single chamber pacemaker, in which the pacing will happen only on the right ventricle, and dual chamber pacemaker, in which the pacing can take place in the atrium and in the ventricle. Here we can see the temporary pacemaker with the external pacemaker and the electrode attached to it. This electrode will go to the right ventricle through the femoral vein, usually to unstable patients before insertion of the permanent pacemaker. The second picture will show the single chamber pacemaker. Here is the generator and the electrode inserted through the subclavian vein to the right ventricle, and the pacing occurs only on the right ventricle, and the ECG showing a wide QRS and a pacing spike preceding every QRS. And this concludes our presentation. Thank you and good luck.